A 70-year-old male presented with complaints of hematuria or a costovertebral pain or palpable mass. So what is your provisional diagnosis? Because our topic for today is renal cell carcinoma, it will be very easy for you to diagnose renal cell carcinoma, but you have to do that in exam. So clinically, remember this triad. Angle. Okay. One is costovertebral pain. Palpable mass. So this triad is characteristic of renal cell carcinoma. This triad, remember this triangle, there's a triad. These three symptoms are very characteristic of renal cell carcinoma. Costovertebral pain, a palpable mass where in the loin region, and hematuria. Out of these three, which is the most common? Which is the most common? Hematuria. Means blood in the urine is most common, hematuria. But unfortunately, most of the hematurias, most of the blood that goes in urine is not overt. It's microscopic, means you cannot see it. It's not overt hematuria. It's occult hematuria. Means you cannot see the blood passing in the urine. And only 10% of patients present with these features. So there are other symptoms also. I'm going to come to that when I teach you the clinical features in detail. So remember this, Karan, why I'm telling you this points are, at your level, এই তিনটে features ই তোমাদের দেবে, not many features, because they don't expect much from you. But renal cell carcinoma is a great mimic of medicine. You know why? Because renal cell carcinoma produces paraneoplastic syndrome. Because renal cell carcinoma presents with paraneoplastic syndrome, and it can present with any features depending on the hormone it secretes, if it's a paraneoplastic syndrome. Okay, that's why it's called a great mimic of medicine. And sometimes, not sometimes, in most cases, renal cell carcinomas metastasize widely before giving rise to any symptoms. That's why symptoms often come very late. Patient presents with symptoms very late, and depending if it has metastasized, depending on which organ has been affected, it can present accordingly. So not necessarily these three will be the clinical features, but at your level you must know, because examiner will ask you, or in exam question paper you may get these three features. One is costovertebral pain, one is palpable mass, and the other is hematuria. So out of these three, put your leg down, put your leg down. Out of these three, which is the most common? Hematuria. And unfortunately, most of the hematurias that the patient presents with is microscopic hematuria, not overt, it's an occult hematuria. Okay, so going with this, I'll straight away go to renal cell carcinoma. Okay, so a brief introduction. It's predominantly what is adenocarcinoma, means what? It's a cell type. I'm not explaining you not giving you the classification of all renal cell tumors, because our topic for today is renal cell carcinoma, and I'm going to keep it as crisp as possible. Okay, so predominantly it's adenocarcinoma, means the cell type, it's adenocarcinoma, depends on the cell of origin. Okay, and it represents 85% of all renal tumors, 85% of all renal cancers, sorry, because there are other cancers also. There is Wilms tumor and all you have studied for your first or second semester in childhood tumors. Okay, so it represents 85% of all renal cancers. Which age group it affects? Which age group it affects? Predominantly senior citizens, 6 to 7 decades. It can affect the 5th decade also, it can affect the 8th decade also, but 6 to 7, that particular 60 to 70 years is the period when maximum renal carcinomas are diagnosed. Males are affected slightly a little more than females. Males are affected a little more than females in a ratio of 2:1. Okay, and previously it was called hypernephroma. Hypernephroma. You know why it's called hypernephroma? Because it resembled the clear cells of the adrenal cortex. Because it resembled the clear cells of adrenal cortex, previously it was known as hypernephroma, but now it's clear that renal cell cancers, depending on the variant, it arises from the renal tubular epithelial cells. It has got nothing to do with the adrenal cortex, but why it is called hypernephroma is because it resembled the clear cells of the adrenal cortex. So any questions from here? Predominantly, what is the cell type? Adenocarcinoma. Means renal cell cancers are predominantly adenocarcinomas, and they represent 85% of all renal cancers. Representing 85% of all renal cancers affecting the senior citizens, the geriatric age group, predominantly as the 6 to 7 decades of life. Males are slightly more affected than females in a ratio of 2:1, and previously they were called hypernephroma. Why hypernephroma? Because the cells resembled the normal adrenal cortical cells. The cells resembled the normal adrenal cortical cells, but now it is clear that all these tumors arise from the renal tubular epithelium. Okay. Okay, so clear. I'm going to the next slide. You keep on asking me what I should write in exams and all. See, all these are written exactly how, I mean, যেভাবে PowerPoint টা তৈরি করেছি, the way I have prepared the PowerPoint, it's exactly how you should write in an exam paper. Okay, give headings, put in bold, highlight wherever it's necessary. It will become very easy for you. So, what are the predisposing factors? One is cigarette smoking. Yes, cigarette smoking, the organ which is affected the most is lungs. But that doesn't mean that cigarette affects only the lungs. Some visceral cancers can also be affected. Some visceral cancers can be aggravated by smoke. One of them is renal cell cancer. Renal cell carcinomas can be affected because of smoking. Whether you take cigarettes or you take cigars or you take pipes, doesn't matter. Everyone who smokes are at increased risk of developing renal cell carcinoma. Then, prolonged exposures to polycyclic hydrocarbons, heavy metals, petroleum, etc. That is number 2. Number 3, adult polycystic kidney disease. Hoye gache. You know what are cystic diseases of the kidney. Adult polycystic kidney disease. This polycystic kidney disease patient predominantly presents with the papillary variant of renal cell carcinoma. The most common is clear cell, then comes the papillary variant, then chromophobe and Bellini duct variant, whatever. I'm going to come into those. But patients who develop polycystic kidney disease after dialysis, this kind of patients develop renal cell carcinoma. And which variant of renal cell carcinoma they develop mostly? That is the papillary variant of renal cell carcinoma. Okay. Then CRF. What is CRF? CRF, chronic renal failure. Hypertension and obesity, especially obesity in women. Hypertension and obesity. Obese women are more predisposed to develop renal cell cancers. And then VHL. Have you heard of VHL? What is VHL? Huh? Von Hippel-Lindau. Von Hippel-Lindau disease. Very good. VHL disease. Then other diseases like tuberous sclerosis is also there, which I have not mentioned, but you can write down. So these are all the predisposing factors. Cigarette smoking, exposure to heavy metals, petroleum, asbestos, etc. Then adult polycystic kidney disease, chronic renal failure, von Hippel-Lindau disease, tuberous sclerosis, and what else? Obesity, especially obese women are more predisposed to develop hypertension, this renal cell carcinoma and hypertension. Okay, so these are the predisposing factors. Coming to the third point, genetics. which genes are affected. See, exactly exam point of view theke ami porachi. This is being taught exactly from the exam point of view. If you write these points, you get a lot of numbers. Are you happy with your exam paper? Huh? Are you happy with the marks? That is VHL gene. VHL gene. What is VHL gene? Von Hippel-Lindau. So von Hippel-Lindau gene, the most common VHL gene. VHL gene is located in which chromosome? VHL gene is located predominantly, VHL gene is associated with clear cell variant. It is located in in chromosome 3. So what exactly goes wrong? What exactly? There is loss of sequence in chromosome 3. There is loss of sequence in chromosome 3. Okay. Start. Loci where VHL gene is located. So there is loss of sequence. Loss of sequence means either it is deleted, either it translocation. Either it is deleted, there is deletion, that is 3p minus, or unbalanced chromosomal translocation, 3:6, 3:8, or 3:11, whatever it may be. Or sometimes the gene is inactive. Either mutation or somatic hypermethylation. So whatever it may be, ultimately it results in the loss of VHL gene, because ultimately it results in the loss of chromosome 3p, and 3p25.3 is the loci where VHL gene is located. So what happens in VHL gene is, what happens when VHL gene is lost or VHL gene is inactivated? There is increased activity of HIF, hypoxia inducible factor 1. Hypoxia inducible factor means what? It gives rise to erythropoietin, yes, pro-angiogenic, and cell growth happens. Okay, more formation of blood vessels, more cell growth, that means uncontrolled mitosis giving rise to what? Cancer. So that's how it is located. So when hypoxia inducible factor is activated, it constitutively activates various growth factors like PDGF, TGF alpha, TGF beta, FGF, etc., ultimately resulting in new blood vessel formation. New blood vessel formation will do what? More cellular growth, uncontrolled mitosis, giving rise to what? Cancer. Hey, giving rise to cancer. Okay, so that is one. The clear cell variant is most commonly associated with VHL gene. Then trisomies of 7, 16 and 17, trisomies of chromosome 7, 16, 17 and loss of Y pattern in male. This is associated with sporadic papillary variant, and trisomy 7, that is associated with familial papillary variant. So at least remember these two forms, that is more than enough. Remember the VHL gene and remember the trisomies. Trisomies of 7, 16 and 17 and loss of Y in male. Obviously Y chromosome will be in male. So that is associated with the sporadic papillary variant, and trisomy 7 is associated with the familial papillary variant. Remember these two genes that is more than enough for you. VHL জিনটা তো মাথায় রাখতেই হবে তোমাদের, okay, because it is associated with the most common form of renal cell carcinoma, that is the clear cell variant. Should I go to the next slide? Okay, so this is what I have been telling you. This is the whole thing which I have explained here. I'm not explaining this anymore. Okay, this is the diagram which is taken from Robbins, and it's the translocation which I just told you, 3, 6, 3, 8, 3, 11, or deletion of chromosome 3, that is loss of VHL, von Hippel-Lindau gene. Okay, so this is the diagram which I have just explained in the blackboard, which I have drawn in the blackboard and I have explained it to you. Okay, so coming to the various variants, the most common is what? Clear cell variant. The most common is clear cell variant. 85% of renal cell carcinomas are clear cell variant. Why they are called clear cell variant? I'm going to come to that. Then after that is papillary variant. Papillary variant because they are shaped like papillae. Then comes chromophobe variant, and finally the collecting duct variant, Bellini duct carcinoma, that is called Bellini duct carcinoma. Okay, so clear cell, papillary, chromophobe, and Bellini duct variant or collecting duct variant. So which cells they arise from? The cells of origin must be remembered. Which cell they arise from? Clear cell arises from the proximal tubular epithelium in the cortex, proximal tubules in the cortex. Papillary variant arises from distal tubule in the cortex. একটা proximal, clear cell proximal, তারপরেরটা papillary variant from distal. Then chromophobe variant arises from the intercalated ducts in the collecting tubules, and finally the collecting duct variant from the collecting duct in the medulla. So just remember the names, at least remember the first two, clear cell variant and papillary variant. These two are the most common. Okay, remember at least the first two, and if possible remember the others also. Okay, morphology. Coming to the gross morphology, in RCCs the poles are most commonly involved. Now you know what are the poles. Kidney তোমরা anatomy করেছো, kidney dissection করেছো, kidney poles কি I am not explaining because you know, I automatically assume that you know what are the poles of the kidney, whether the upper pole or the lower pole. So any poles can be involved. So এই যে পিকচারটা দেখতে পাচ্ছো, don't you think the pole is involved? The pole is involved, right? So this tumor, the clear cell variant, predominantly the papillary variant are by will be of multilateral, but clear cell variant is generally unilateral. So this is a clear cell variant. You can see the entire kidney is free, but one of the poles is affected. So this is unilateral and solitary. The lesions are unilateral and solitary. The spherical lesion having bright yellow, they are bright yellow in consistency and sometimes gray white. Spherical lesions, bright yellow to gray white lesion, they can be sometimes big enough to distort the renal architecture. They can be sometimes big enough to distort the renal architecture. On cut surface reveals areas of necrosis and hemorrhage. Cut surface reveals areas of necrosis and hemorrhage. These are all necrosis and hemorrhage. A lalta hocche hemorrhage. So these whitish areas, these are all necrosis, whereas these are areas of hemorrhage. Okay. It can invade the adjacent pelvis, it can invade the adjacent calyces and totally destroy the renal architecture. And sometimes it can grow big enough to rupture the renal capsule and grow into the adjacent structure. Invasion of renal vein is a characteristic feature of renal cell carcinoma. First, the renal vein is inside the renal vein, the tumor grows as columns of cells, finally affecting the inferior vena cava. From renal cell, it can affect the inferior vena cava, and from inferior vena cava, it can go into the right side of the heart. Okay, that is one characteristic of renal cell carcinoma. It can involve the renal vein. From the renal vein, it can go into the inferior vena cava, finally going into the right side of the heart. This much is finally going into the right side of the heart. So again, just summarizing, which part of the kidney is most commonly affected? The poles. Oh, the poles are most commonly affected. The clear cell variants are generally solitary and unilateral. Mane ekta dike effect korbe, solitary and unilateral. From the picture you can make out. Okay. Spherical lesions, colorটা কি হবে? Bright yellow to gray white lesion. Bright yellow to gray white. Solitary, bright yellow to gray white lesions. Sometimes the tumor can invade the pelvis and calyces and rupture the renal capsule to invade the adjacent structures. In doing so, because the tumor grows, there can be areas of necrosis and hemorrhage. Why necrosis? Why hemorrhage? Because it can erode the adjacent blood vessels. Okay. And finally, one important characteristic of renal cell carcinoma is the invasion of the renal vein. The invasion of the renal vein. The renal vein is invaded. From renal vein, the inferior vena cava, the tumor cells grows as the tumor grows as columns of cells in the renal vein. From the renal vein, it goes into the inferior vena cava. From inferior vena cava, it can grow into the right side of the heart. So that is one characteristic of renal cell carcinoma. Okay. Then coming to the papillary variant are multifocal in contrast to unilateral, in contrast to clear cell carcinoma. The papillary variant, they are multifocal and bilateral. And there can be areas of hemorrhage along with cysts. Why cysts? What I told you in the previous slides when I was explaining. Why cysts? Because it arises in patients with polycystic kidney disease, especially patients undergoing dialysis. If they develop polycystic kidneys, from polycystic kidney, from those patients are more predisposed to develop renal cell cancers. And which variant of renal cell cancers they develop? Mostly papillary variant. Okay, right. Then comes the chromophobe variant. They are light brown and hemorrhage. They are light brown with areas of hemorrhage, but necrosis is not very common. There can be areas of hemorrhage. There may not be areas of hemorrhage. Hemorrhage may or may not be present, but necrosis is very rare, and they are light brown in color. And finally, Bellini duct variant. Just remember, circumscribed, it's well circumscribed with areas of necrosis. Remember clear cell variant, because that is the most common, 85%, and definitely you're going to get, if question comes, the answer expected out of you is the clear cell variant. That's what we expect out of you. Okay, so remember the variant. The first and foremost is the clear cell variant, then comes the papillary variant. A few important characteristics of papillary variant is, in contrast to clear cell variant, is necrosis is less common in papillary variant, but they are cystic. Why they are cystic? Because it arises in patients with what? Polycystic kidney disease, especially patients who have undergone or who are undergoing dialysis. Why patients will undergo dialysis? Because they have renal failure. That's why they are undergoing dialysis, and such patients undergoing dialysis are more predisposed to develop what? Polycystic kidney disease, and from those cysts, a renal cell carcinoma can arise. And if a renal cell carcinoma arises from polycystic kidney disease, what will be your answer? What is the variant? Papillary variant of renal cell carcinoma. Okay. Then comes the chromophobe variant and Bellini duct variant. So, why it is called clear cell? Why it is called clear cell? Cells are clear. Very easy. Clear cell variant because the cells are clear. Why cells are clear? What happens? Yes, they contain. What happens in lipoma? Fat gets washed away. Similarly, the glycogen ache. The glycogen gets washed away. That's why they are clear in nature. So round or polygonal cells with prominent outlines, having abundant clear or granular cytoplasm, having abundant clear or granular cytoplasm with delicate branching vasculature, okay. Sometimes other growth patterns can be seen, solid trabecular or tubular growth patterns. So solid trabecular or tubular growth patterns can also be seen. What is, what is solid? What is trabecular? Cord-like. What is trabecular? Cord-like. And tubular means in the form of tubules. You know how renal tubules look like. So why clear cell variant? Because the cytoplasm contains abundant clear or granular, because the cytoplasm is, they contain glycogen. That's why during paraffin embedding, the glycogen gets washed away. That's why the cytoplasm is clear or granular. The cells are round or polygonal shaped cells with prominent cytoplasm, having abundant with the prominent cell membranes, having abundant granular or clear cytoplasm with delicate branching vasculature. The growth pattern may be solid, trabecular or tubular. So this is the microscopic feature of clear cell carcinoma. Then comes the papillary variant. The papillary variant, as the name suggests, will be arranged in the form of papilla. The growth pattern will be papillary, composed of low columnar or cuboidal cells. The renal tubular epithelial cells will be low columnar or cuboidal cells. This tumor will be composed of low cuboidal or columnar cells arranged in the form of a papilla, and sometimes in the core of the papilla you can get interstitial foam cells or psammoma bodies. Interstitial foam cells or psammoma bodies may be available in the core of the papilla. Then comes chromophobe variant. The chromophobe variant, see papillary carcinoma বুঝতে কোনো problem নেই. You know how papilla looks like. Have you seen a papilla before? We will try. I don't know whether I'll be able to, but I'll definitely be able to show you a clear cell. ওরকম না, মাইক্রোস্কোপিতে কিরকম দেখতে ওইরকম। Great, very good. Then comes the chromophobe variant. Remember, clear cell variant, the cytoplasm is clear, whereas chromophobe variant, the cytoplasm will be pale eosinophilic. If I ask you to contrast this cytoplasm clear versus this cytoplasm, will you be able to differentiate? একটা totally clear, whereas একটা কি আছে? Pale eosinophilic cytoplasm with a perinuclear halo. এখানে very prominent নেই, but there are perinuclear halos. Means in and around the nucleus, the cytoplasm will get washed away. So it will give you a clear appearance, a halo. That is called a perinuclear halo. What is peri? Means around. So chromophobe variant, pale eosinophilic cells with perinuclear halo arranged in solid sheets. And last is the collecting duct variant. I don't have a picture of it. It has a hobnail pattern of appearance. So if you remember this two at least, clear cell and papillary, more than enough. And remember, in chromophobe variant, what you get is pale eosinophilic cells with perinuclear halo. Okay. ঘোড়ার খুর দেখেছিস? ঘোড়ার খুর, হ্যাঁ, হবনেল ওরকমই, হবনেল ওপরে। The clinical features which I have just explained, the triad, clinical features, the triad আছে. What, man? So manifestation আমি triad আছে. Three things are important. What are the three things? বল।
Hematuria, costovertebral pain or palpable mass.
Palpable mass, ঠিক আছে. Which is the most common? Hematuria. So 10% of patient presents with, now let me explain you in details. 10% of the patients present with hematuria. Sorry, not 10%, sorry, I said something wrong. 10% of patients may present with these features. 90% of patients will not present with such features. So it's very difficult to actually diagnose the case. And even if hematuria, out of these three, hematuria is the most common. Most of the hematuria that the patient presents with is microscopic. So if you do not do a urine examination, especially the microscopic examination of urine, or if you don't do a benzidine test, you will not be able to identify the blood in the urine. Right? That's why these patients are diagnosed late. And by the time these patients are diagnosed, it may have metastasized. It may have metastasized. So that has a very ominous, these patients may present with a very ominous prognosis. The prognosis for these patients may be very bad. So these are the classical manifestations, the triad manifestations. But other than that, there can be constitutional symptoms. As the tumor grows, patient is not aware that there is a tumor, but the patient has fever, malaise, weakness, weight loss, all the manifestations of a malignancy. Patient can present with such constitutional symptoms also. Not necessarily loin pain, not necessarily a costovertebral pain or a palpable mass in the loin or blood in the urine, hematuria. Patient may present with other constitutional symptoms also. Eta to hoye gelo. But as I have mentioned in the very beginning, that renal cell carcinomas are a great mimic of medicine. Why? Because it produces paraneoplastic syndrome. So patient can present with features of paraneoplastic syndrome. It can be anything, depends on which hormone it secretes. For example, if it secretes renin, it will cause hypertension. If it secretes erythropoietin, polycythemia. What is polycythemia? Opposite of anemia is polycythemia. When hemoglobin যদি কম হয় তাহলে সেটা হলো অ্যানিমিয়া, তার উল্টোটা হলো polycythemia. Right? Erythropoietin কি প্রোডিউস করবে? Obviously, so there will be polycythemia. Parathormone like peptide, তাহলে hypercalcemia. Right? Huh? Malaise মানে generalized weakness, একটা feeling of uneasiness, ওটা হচ্ছে malaise. Feminization or masculinization, depending on which gonadotropins it secretes. So it can secrete gonadotropin and cause feminization or masculinization. Cushing syndrome, because of adrenocorticotropic hormone. এগুলো সব পড়েছে স্তরফিজিওলজিতে, রাইট? সো renal cell carcinoma is a great mimic of medicine because it produces, other than the manifestations that it produces, it also produces paraneoplastic syndrome due to ectopic hormone production. And depending on which hormone is secreted or which hormones are secreted, patients will present accordingly. So if renin is secreted, patient generally presents with hypertension. Patiented blood শুধু একটাই symptom patient present করেছে, that is what? Hypertension. Blood pressure বেড়ে গেছে, ডাক্তারবাবু আমার প্রেসারটা খুব বেড়ে গেছে, মাথা ব্যথা করছে, প্রেসার দেখলে বেড়ে গেল. You just give what? Start with amlodipine, or you just give some antihypertensive, but you don't know that actually there is a hidden malignancy and it is a renal cell carcinoma which requires immediate intervention. That's why it's a mimic. You don't know what the patient will present with. So patient presents with hypertension because of renin secretion or polycythemia. Polycythemia যদি হয়, how will the patient present with? How will the patient present with? At a simple word, polycythemia. Anemia যদি থাকে, patient কি blood viscosity বেড়ে গেলে কি হবে? What can happen if there is blood? Yes, correct. Polycythemia তে there will be blood viscosity. So how will the patient present with? And a viscous Raynaud's, you think যদি blood viscous হয়ে যায় তাহলে কি হবে? Exactly, blood viscous হলে ব্লাডটা ফ্লোই করবে না, ইসকেমিয়া হতে পারে, তারপরে তোমার অনেক ফিচার্স হতে পারে. You can get syncope and all. কোনো জায়গাতে ব্লাড যাবে না তো, মাথায়, স্পেশালি মাথায় ব্লাড যাবে না, right? Because blood is viscous. So that can be a presenting feature. Then other features depending, I'm not explaining hypercalcemia, it can present with bone fractures and all, whatever it may be. Feminization or masculinization, অনেক features আছে. Then Cushing syndrome আমাকেও পড়তে হবে. ওকে, ওই তো বাফেলো হামটাম, অনেক কিছু হতে পারে, মুনস ফেস, আমি ভুলে গেছি, ঠিক আছে? So these are all the paraneoplastic syndromes, right? এই হয়ে গেছে, চলো, এখান থেকে যায় না কেন, এটা দূর থেকে Patient can have lower leg edema. Why lower leg edema? Because of extension of tumor into the inferior vena cava. Right renal vein থেকে কোথায় যায়? Inferior vena cava, from there into the right side of the heart. So patient can present with edema of the lower leg. Left-sided varicocele because of obstruction of the testicular vein. কিভাবে testicular vein obstruct করবে? Because the testicular vein drains into the renal vein, left renal vein. So left renal vein এ যদি tumor থাকে তাহলে testicular vein will not be able to drain into the renal vein. That means patient will present with what? Left-sided varicocele. Pathological fractures, especially of the femur and the hip, because of metastasis to the bones. And then there can be manifestations if it metastasizes to the lung or opposite kidney, adrenals, gingiva, CNS, larynx, bronchi, nasal cavity, skin, soft tissue. It can metastasize anywhere. Most common site is lung. So patient will present accordingly. So remember the first three at least. Lower leg edema, why? Because of extension of tumor into the inferior vena cava. Left-sided varicocele because obstruction of the left testicular vein. Why the left testicular vein will, what happens? Left testicular vein drains into the renal vein, and if the renal vein is obstructed, since I came back, I'm having this for almost 1 month. So left-sided varicocele because of obstruction of the left testicular vein, because the left testicular vein drains into the left renal vein, and if the left renal vein is invaded by tumor, the tumor grows into the left renal vein, the left testicular vein will not be able to drain into the left renal vein, and that's why you're going to get what is known as a left-sided varicocele. Pathological fractures can be because of metastasis to the bones, especially the femur, the head of the femur and hips. Okay. So how does the tumor spread? There's a local spread, the lymphatic spread and hematogenous spread. Local spread কোথায় হতে পারে? Into the renal capsule, perinephric fat, renal vein, then inferior vena cava and right side of the heart. These are all the local spread. Lymphatic spread into the adjacent lymph nodes, especially the para-aortic lymph nodes. And hematogenous spread means via blood. The most common organ involved is the lung, 50% lung. Then in lower order of frequency, decreasing order of frequency, it can go into the bones, liver, skin and brain. But most common site to be involved is the lung via hematogenous spread. Okay. Finally, coming to the laboratory investigation. So this is the last part. You have to do hemogram. Just remember these points. Urine analysis, look for hematuria. Blood biochemistry, look for serum calcium levels. LFT, RFT and imaging techniques. Ultrasound of the whole abdomen, especially kidneys. Ultrasound of the whole abdomen, especially kidneys. IV, intravenous pyelography, renal arteriography, bone scan, sometimes CT scan, MRI. Remember, most of the renal cell carcinomas are diagnosed when we do a scan of the abdomen, whether it's when we do a radiological examination of the abdomen for non-renal reasons. For non-renal reasons, patient is doing an ultrasound of the abdomen, maybe for something else, and accidentally the radiologist discovers that there is a mass in the kidney, and biopsy is done, and what is revealed is a renal cell carcinoma. So many of the renal cell, not all, of course not all, but many renal cell carcinomas are diagnosed when a patient undergoes a radiological examination of the abdomen for non-renal reasons. Patient doesn't even know that there's a malignancy. The patient has done an ultrasound of the abdomen for reason other than a pathology in the kidney, and what turns out to be the most dreaded complication, that is there is a pathology in the kidney. And what type of pathology is it? It's a cancer. There's a mass in the abdomen, there's a mass in the kidney, and more or less radiologists will be able to give you a correct diagnosis that it is a malignancy. Then a biopsy is done, and finally it is revealed that it's a renal cell carcinoma. Clear? So this finishes the topic on renal cell carcinoma. One important topic is over.